ಸೈಕ್ಯಾಟ್ರಿ ಸೆಲ್ನ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಕಾರಂತ್ ಅವರ ಅಧ್ಯಕ್ಷತೆಯಲ್ಲಿ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮ ಪೇಡ್ ಸೈಕ್ಯಾಟ್ರಿ ಅಕಾಡೆಮಿಕ್ಸ್ ಫಾರ್ IMA ಡಾಕ್ಟರ್ಸ್ ನ 5ನೇ ಅವತರಣಿಕೆಯನ್ನು ಶುರು ಮಾಡ್ತಾ ಇದೀವಿ ಈಗ. ಸೊ ಇಂದಿನ ಒಂದು ಸಭೆಗೆ ಡಾಕ್ಟರ್ ವೆಂಕಟಾಚಲಪತಿ IMA ಅಧ್ಯಕ್ಷರು ಅನಿವಾರ್ಯ ಕಾರಣಗಳಿಂದ ಬರ್ಲಿಕ್ಕೆ ಆಗ್ತಾ ಇಲ್ಲ, ಗೈರುಹಾಜರಾಗಿದ್ದಾರೆ. ಅವರ ಅನುಪಸ್ಥಿತಿಯಲ್ಲಿ ಡಾಕ್ಟರ್ ಉಮಾ ಶೇಷಗಿರಿ ರಾವ್ ಇವರನ್ನು ನಾನು ಹೃತ್ಪೂರ್ವಕವಾಗಿ ಈ ಒಂದು ಪೇಡ್ ಸೀರೀಸ್ ಕಡೆಯಿಂದ ಹೃತ್ಪೂರ್ವಕವಾಗಿ ಅವರನ್ನ ಸ್ವಾಗತಿಸ್ತಾ ಇದ್ದೀನಿ. ನಮಸ್ತೆ ಮೇಡಮ್. ಹಲೋ. ಅದೇ ರೀತಿಯಾಗಿ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ನಮ್ಮ IMAKSB ಅಧ್ಯಕ್ಷರಾಗಿರ್ತ ಕಾರಂತ್ ಅವರನ್ನು ಹಾಗೂ IMA ಸೆಕ್ರೆಟರಿ ಆಗಿರ್ತಕ್ಕಂಥ ಪ್ರಸಾದ್ ಅವರನ್ನು ಮತ್ತು ಹರೀಶ ದಲಂತ ಭಟ್ ಮತ್ತು ಇನ್ನಿತರ ಎಲ್ಲ ಶಿಬಿರಾರ್ಥಿಗಳ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಹಾಜರಾದ ಎಲ್ಲ ವೈದ್ಯರನ್ನು ಹೃತ್ಪೂರ್ವಕ ಸ್ವಾಗತಿಸುತ್ತಾ ಮತ್ತೊಮ್ಮೆ ನಾನು ಈ ದಿನದ ಈ ಒಂದು ಪೇಡ್ ವೆಬಿನಾರ್ ಸೀರೀಸ್ಗೆ ಮತ್ತೊಂದು ಹೊಸ ಮುಖವನ್ನು ಇವತ್ತು ನಿಮ್ಹಾನ್ಸ್ ಇಂದ ಪರಿಚಯ ಮಾಡಿಸ್ತಾ ಇದ್ದೀವಿ. ಸೊ ಅದನ್ನ ಡಾಕ್ಟರ್ ಮಂಜುನಾಥ್ ಅವರು ಅವ್ರನ್ನ ಪರಿಚಯ ಮಾಡಿಸ್ಕೊಡ್ತಾ ಇದ್ದಾರೆ, ಡಾಕ್ಟರ್ ನಿಶಿರಾ ಅಂತ ಅಂದ್ಬಿಟ್ಟು. ಸೊ ಡಾಕ್ಟರ್ ಮಂಜುನಾಥ್ ಬಗ್ಗೆ ಮತ್ತೆ ಹೆಚ್ಚಿಗೆ ಹೇಳೋ ಅವಶ್ಯಕತೆ ಇಲ್ಲ. ಟೆಲಿಮೆಡಿಸಿನ್ ಮತ್ತು ಕಮ್ಯುನಿಟಿ ಸೈಕ್ಯಾಟ್ರಿ ಡಿಪಾರ್ಟ್ಮೆಂಟಿನ ಒಂದು ನಿಮ್ಹಾನ್ಸ್ ನಲ್ಲಿ ಕಾರ್ಯನಿರ್ವಹಿಸ್ತಾ ಇದ್ದಾರೆ. ಸೊ ಅವ್ರನ್ನ ಹೃತ್ಪೂರ್ವಕವಾಗಿ ಡಾಕ್ಟರ್ ಮಂಜುನಾಥ್ ಅವರನ್ನು ಸ್ವಾಗತಿಸುತ್ತಾ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಮಂಜುನಾಥ್ ಅವರು ನಡೆಸಿಕೊಡೋಕ್ಕಿಂತ ಮುಂಚೆ ಡಾಕ್ಟರ್ ಉಮಾ ಶೇಷಗಿರಿ ರಾವ್ 2 ಮಾತು ಹೇಳ್ಬೇಕಂತ ನಾನು ಕೇಳ್ತಾ ಇದ್ದೀನಿ.
Sir, thank you. At the outset, I would like to thank you all and congratulate you all, sir, especially stalwarts from NIMHANS as well as stalwarts from IPS Karnataka chapter. So, idanondu karakrama, you are doing such a wonderful job by educating us all, general practitioners as well as specialists. So, namge idrinda tumba upayoga agta ide. So, we are very thankful to you and continue like this only, and thank you so much.
ಥ್ಯಾಂಕ್ ಯು ಮೇಡಮ್. ನಮ್ಮ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಕಾರಂತ್ ಅವರು 2 ಮಾತು ಹೇಳೋಕ್ಕಿಂತ ಮುಂಚಿತವಾಗಿ ಇದರ ರೂವಾರಿಗಳಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಮಧುಸೂದನ್ ಅವರಿಗೆ ಮತ್ತೊಮ್ಮೆ ನಾನು ಧನ್ಯವಾದಗಳನ್ನು ಸಲ್ಲಿಸ್ತಾ ಮಧುಸೂದನ್ ಕಾರಿಗರ್ ಅವರು ನಿಕಟಪೂರ್ವ ಅಧ್ಯಕ್ಷರನ್ನು ಕೂಡ ಸ್ವಾಗತ ಮಾಡ್ತಾ ಇದ್ದೀನಿ. ನಮಸ್ಕಾರ. ನಮಸ್ಕಾರ.
ನಮಸ್ತೆ.
ಓಕೆ, ಡಾಕ್ಟರ್ ಕಾರಂತ್ ಸರ್.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಇದು ಸೋಮಶೇಖರ್ ಬಿಜಲ್ ಅವರು ಹೇಳಿದಾಗೆ ಇದು 5ನೇ ಅವತರಣಿಕೆ. ಇಷ್ಟರವರೆಗೆ 4 ಅವತರಣಿಕೆಯಲ್ಲಿ ಇದು ಶುರು ಮಾಡಿದ್ದೇ ನಮ್ಮ ಮಂಜುನಾಥ್ ಅವರು. ಒಳ್ಳೆಯ ಒಂದು ಪ್ರತಿಕ್ರಿಯೆ ಬಂದಿದೆ ಹಾಗೂ ತುಂಬಾ ಜನ ಫಲಾನುಭವಿಗಳು ನನಗೆ ಫೀಡ್ಬ್ಯಾಕ್ ಕೂಡ ಕೊಟ್ಟಿದ್ದಾರೆ. ಇದು ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಖಂಡಿತವಾಗಿ ಇದೊಂದು ನಿರಂತರತೆಯನ್ನ ಕಾಪಾಡಿಕೊಂಡು ಬರ್ಲಿಕ್ಕೆ ನಾವೆಲ್ಲ ಶ್ರಮಿಸುವ. ಮತ್ತೆ ಈ ಒಂದು ವೆಬಿನಾರ್ ಏನಿದೆ, ಇವತ್ತಿನ ಟಾಪಿಕ್ ಏನು ಸೋಮಶೇಖರ್
ಸರ್? ಇವತ್ತು ಸಬ್ಸ್ಟೆನ್ಸ್ ಯೂಸ್ ಡಿಸಾರ್ಡರ್.
ಇದು ಬಹಳ ವೆರಿ ಮಚ್ ಬಹಳ ರೆಲೆವೆಂಟ್. ಟೊಬ್ಯಾಕೋ ಅಂಡ್ ಸಬ್ಸ್ಟೆನ್ಸ್, ಇದು ಆಲ್ಕೋಹಾಲಿಸಂ ಕೂಡ ಇದನ್ನ ಕವರ್ ಮಾಡ್ತಾರ ಅಂತ ಕಾಣುತ್ತೆ.
ಆಲ್ಕೋಹಾಲ್ ಮತ್ತು ಟೊಬ್ಯಾಕೋ ಅಡಿಕ್ಷನ್.
ಓಕೆ, ಅದೆಲ್ಲ ಒಂದಕ್ಕೊಂದು ಅದು ಬ್ರಹ್ಮರಾಕ್ಷಸ ಇಬ್ರು ಒಂದು ಕರ್ನಾಟಕದ ಮೂಲಕ. ಆದ್ರೆ ಒಳ್ಳೆಯ ಒಂದು ಟಾಪಿಕ್, ವೆರಿ ಮಚ್ ರೆಲೆವೆಂಟ್. ಬಹುಶಃ ಇನ್ನು ಕೂಡ ಕೆಲವರು ಜಾಯಿನ್ ಆಗ್ಲಿಕ್ಕಿದ್ದಾರೆ. ಇಟ್ ಇಸ್ ಟು ಅರ್ಲಿ ಅಲ್ಲ. ಎನಿವೇ, ಐ ವಿಶ್ ದಿ ವೆಬಿನಾರ್ every success on behalf of IMAKSB psychiatry cell. Thank you one and all. Thank you.
Okay, thank you. Now may I request Dr. Manjunath sir, I welcome and request him to moderate the session, sir.
Thank you very much, Dr. Bichal. Thanks to IMA, thanks to Dr. Karignur for giving us opportunity to talk in a big platform of IMA. Thanks to IPSKC, where Dr. Bichal is really working hard to coordinate this thing. And yes, we have promised initially that initial 6 webinars will be run by NIMHANS people. After that, we will be open to non-NIMHANS IPSKC group. Something like that. Alva Bijal Aure? So that kind of...
That was the plan, sir.
Yeah, that was the plan. So this is the 5th webinar series where one of the lady psychiatrist, she is working with us, and it is my pleasure to introduce her. She is Dr. Lakshmi Nirisha. She did her MD psychiatry from St. John's Medical College. Subsequently, she has worked with us as a senior assistant, and now she is working with as an assistant professor of psychiatry. One of her main area of current area is to train MBBS doctors, and currently she is training at Chhattisgarh state and Karnataka Ramnagara district. that kind of thing that she is working. So it is very relevant for her work. So I requested her to be part of the paid webinar rather than I only talk. I want many people to join with hand with us. So she agreed, and thanks Dr. Lakshmi Nirisha to come in this webinar. And this topic is alcohol and tobacco. Karan sir ಅವರು ತುಂಬಾ ಮರ್ಮವಾಗಿ ಹೇಳ್ತಾ ಇದ್ರು, ತುಂಬಾ ಏನೋ ಹೇಳಿದ್ರಲ್ಲ, something like that. Okay, alcohol, tobacco, whether we like, we don't like alcohol, tobacco. And I will just share my experience about tobacco. When I joined for DPM in 2005, 2002 in NIMHANS, tobacco history na ನಾವು ತಗೊಳ್ತಾನೆ ಇರಲಿಲ್ಲ. It was so it was not found as a relevant that point of time. By that time, when I finished my DPM by 2004, just started that we were asked to take the history of tobacco usage in all patients. So our time last 15 years only, there are major changes has happened in the treatment aspect of tobacco. And tobacco only, it is not very big to do anything in when you come across the tobacco addiction. It's just you need to know what question to ask, how to make diagnosis, what prescription to be written. It hardly takes couple of minutes to do that kind of prescription. And coming to alcohol, whether we like or we don't like, our patients are having alcohol addiction or usage or that kind of things. So in that case, all MBBS doctors come across both the illness. And as a psychiatrist, we don't want to talk very high-fi things about management of alcohol addiction and tobacco. We want to keep it as simple as possible, which will be attractive to all MBBS doctors, so that they should feel that, yeah, I can also do it at my clinic, in busy clinic. So that kind of approach we are having here. And I would request Dr. Lakshmi Nirisha to begin her presentation in that case. ನಿಮ್ಗೆ ಇದು ಕೊಟ್ಟಿದಾರ ನೋಡಿ access?
ಒಂದು ನಿಮಿಷ ಎಸ್ ಸರ್, ಐ ಆಮ್ ದ co-host ಸರ್, ನಾನು ಶೇರ್ ಮಾಡಬಹುದು. ಹಾ ಸರ್, co-host ನಾನು ಶೇರ್ ಮಾಡಬಹುದು.
ಬಿಜಲ್ ಅವರೇ ಶುರು ಮಾಡ್ಕೊಳ್ಳಿ ಅಲ್ಲ ನಿರೀಶಾ?
ಖಂಡಿತ ಸರ್, ಖಂಡಿತ.
ಥ್ಯಾಂಕ್ ಯು.
Good evening to all. First of all, I would like to thank my teacher and my mentor Manjunath sir ಅವರು ಸರ್ ಇಲ್ಲ ನೀವು IMA ಮಾಡಿ ಇಷ್ಟು ಸೀರೀಸ್ ಎಲ್ಲ ಮಾಡಿದೀವಿ ಅಂದಿದ ತಕ್ಷಣ I was very happy. And the topic that he has given, like sir ಹೇಳಿರೋ ತರ, ಇದು ತುಂಬಾ important topic, and it is a common problem which as other medical specialty professionals you will definitely encounter. I don't think alcohol and tobacco is restricted to one specialty. Every specialty encounters this problem in one way or the other. So I will try my best to like talk about these disorders and see how it will be helpful ನೀವು ನಿಮ್ಮ practice ಅಲ್ಲಿ either in OPD or in patients, whether it will be helpful. So please give us your valuable feedback at the end of the presentation. And also I would like to thank IMAKSB and IPSKC for giving me this opportunity. And it is definitely a very good experience. It will be a good experience for me to reach out to many more of my other specialty seniors and peers. So thank you one and all. So I'll just begin my presentation now. So please interrupt me whenever you feel you haven't understood anything, or you would like to discuss any that all of you encounter during your routine practices. So feel to interrupt during the presentation. So yes, so this is our fourth topic discussion in our paid series, IMA webinar series. So what is the objective of today's topic discussion is that first we are going to focus specifically on tobacco and alcohol. Like I said, it is one of the these two are the most common substance use disorders that in general practice all of you will encounter. So our first objective would be to understand what tobacco use disorders are, management of tobacco use disorders, alcohol use disorders, and their management. So first I will be talking about tobacco addiction. So I think the burden of tobacco use and the problems that come with it, definitely all of you are aware, and the morbidity and the mortality that it causes is very huge. India is actually the second largest consumer of tobacco in the world. After China, we are the largest consumer in the world. And it is the most common substance abuse in India. Unlike people assume that probably alcohol or other drugs are the ones which actually cause addiction, but actually tobacco is the most common substance of abuse. And 21% of population uses some form of tobacco. And more than 40% males and 14% females use tobacco in some form. And smokeless and chewable tobacco is actually more prevalent in India. Unlike what we encounter, which we obviously see is cigarette and BD smoking, but actually in India, smokeless and chewable tobacco is actually the most common one. And both forms of tobacco, that is smokable and smokeless form, both are equally addictive. And as we all know, there is no safe level for its exposure. So any form of exposure to tobacco kills half of its users. And as I've mentioned, it is an important cause of mortality and morbidity globally. So what actually causes tobacco addiction? What is the actual etiology? As you all know, tobacco is actually a plant product. So what is that is consumed is the tobacco leaf, and the tobacco leaf contains the nicotine, which is a plant alkaloid. So actually nicotine is the one which causes the addiction, which is present in the tobacco leaf. And usually the additives that are added to cigarette or BD or even to chewable tobacco forms basically attempt to make it more palatable to the consumer, and often are the primary cause for medical complications. So than the tobacco leaf itself, the additives are the one which cause more complications. And as I've mentioned already, tobacco use comes in two forms, that is smokable form, which is our cigarettes, BD, and chutta, which is more of traditional local form of using tobacco leaf. Smokeless tobacco, wherein the tobacco leaf is mostly chewed upon to release the nicotine, etc., which comes in various forms that are sold openly in retail. So this is just a picture to show you what are the different forms of smokable forms of tobacco use. As you can see, the leaves itself are crudely rolled and smoked, which is commonly called as chutta in South India. So next, coming to the screening and diagnosis of tobacco addiction. So all of us know tobacco causes morbidity, mortality, but how often do we screen and how do we diagnose tobacco addiction is something that we need to make it more of a condition habit rather than something to be asked only for specific set of patients. So and this is also important, why you need to screen all patients is that most of them perceive that it is not, their use is actually not a problem, especially smokeless form of tobacco. They feel it's not causing any trouble. So most of the time family also feels that it is a harmless habit that individual has. But it is important, therefore, to screen all patients who are visiting your clinic. And quickly, how you can screen for patients with tobacco addiction in your OPDs or in patient rounds is a simple question. Do you use BD, cigarettes, gutka, or any other tobacco products within 1 hour of getting up from the bed in early morning? So answer yes to this question is definitely indicative of tobacco addiction. This is a simplified question that we have framed in our clinical schedules of primary care psychiatry that we all are already familiar with. So this is one common feature where most people who have tobacco addiction do is that they immediately get up from bed and they use tobacco. Most of them have the perception that they cannot actually use the toilet without using tobacco. So this is basically indicative of the craving, the withdrawal that they experience through the not using tobacco over. So other screening tools that are available, which may be self-administered with the patient, is that Fagerstrom's test for nicotine dependence. So it basically has about 6 questions and it actually gives you a score. So if is unwilling or not really thinking that my tobacco use is not of much problem, this may be a useful way of screening tobacco use disorders in the patient. So score of 0 to 3 in any of these questions indicates to 6. This is useful when using. It might not be useful for smokable, smokeless form of tobacco. So next is how do we diagnose? So when we say screening, yes, we screen for this thing, but how to really diagnose tobacco addiction and say that yes, definitely this patient has tobacco addiction, is these two important clinical features, is that use of tobacco products regularly and heavily, and inability to control the use and its quantity. So these are the this features, clinical features, that definitely indicate that the person has. So it will be easier sometimes to impart education to the patient, like you have these two problems, so definitely you have tobacco addiction. So like I mentioned, the every addiction has withdrawal associated with that. Unlike the common notion that people don't experience withdrawal with tobacco, tobacco actually has a set of withdrawal symptoms, and usually they start within 3 to 24 hours of stopping tobacco use. And without treatment also, it usually takes about 3 to 4 weeks to gradually resolve. But within the period of these 3 to 4 weeks taking tobacco, so he cannot really remain abstinent for more than a couple of days or maximum a week. So usually he relapses very quickly. So what are the symptoms of tobacco withdrawal? Usually patients experience anxiety, frustration, restlessness, anger, mood symptoms they experience, craving and difficulty to concentrate, insomnia, depressed mood, decreased heart rate, and issues with their appetite, where they experience actually increased appetite, and which eventually can lead to weight gain. So any of these symptoms, especially these, become important if you have inpatients in the wards, and suddenly you notice that a patient who's come with maybe COPD or just for a normal surgery suddenly is becoming quite restless, and he's becoming a little difficult to manage. He's not been sleeping well, and you notice that he's developing unexplained bradycardia. Probably it will be a good idea in such patients to see if they're actually taking some substances. And tobacco is one common tobacco substance use that can be present. So screening for such patients where unexplained anxiety, frustration, all that is noticed in your inpatients, it will be a good idea to examine if they have tobacco use and then whether they're experiencing tobacco withdrawal. So next, coming to the management of tobacco use disorders. So actually in tobacco use disorders, I am discussing first the non-pharmacological techniques, because it's one of the most important things. Though the management is actually not very difficult, but motivating the individual to stop tobacco, to seek help, accept treatments is actually quite difficult, because like I mentioned earlier, most of them perceive it is not a major issue and it is actually not causing much of a problem to them. So first important step would be to educate individuals about the harmful effects of tobacco and the benefits of stopping. So like you can see in this figure that I've put up, is that within a few minutes, like within 20 minutes, a lot of physiological changes start occurring once a person, stops smoking especially. And over a period of time, the long-term risk factors that they develop for either coronary artery disease, for stroke, for cancers, all that gradually actually comes down. So a quick education about the benefits and the long-term benefits of stopping smoking or tobacco use, it will be definitely useful to motivate the individual. And during routine healthcare visits of the patient, like patient is coming for a prescription of hypertension or just coming for prescription for this, educating the patient, about the fact that he or she is using a substance, maybe it's a good idea to stop. It might actually decrease the need for, higher doses of medication, might actually help better control their medical comorbidities. And again, to discuss the treatment options that are available. This is again very important, is that I'm sure most of you would have been oblivious as to what we can do for a tobacco patient with tobacco dependence, until and unless you're somebody who's a pulmonologist who are working, you have your own tobacco cessation clinic running in liaison with psychiatry or running independently. Most of them are actually unaware about the treatment options that are available. So definitely discussing these treatment options with the patient will be very useful to motivate them to quit the substance. So next, coming to the pharmacological management of tobacco dependence. So first is the nicotine replacement therapy. Like I mentioned earlier, the fact that in tobacco use is the nicotine. So, and like I also mentioned that, the additives are the ones which cause most of the adverse effects and the complications. So replacing, removing all the additives, but just giving them nicotine will actually enable us to gradually taper off the use and then stop tobacco altogether. So nicotine replacement therapy actually has a rationale of to reduce the need to take the tobacco products and help to deal with craving and withdrawal symptoms, which will motivate the person further to stop the tobacco use. And what are the various pharmacological preparations that are available for nicotine replacement therapy or NRT? Is that we have gums, which are actually very easily available. People can actually go and buy it without any prescription, so they can actually purchase it in any pharmacy now. And like you all know, you must have seen a lot of ads that are also coming on TV and everywhere to educate the people that this in fact is quite easily available. Patches are also quite useful and more advantageous form of NRT that is available in India. So there are a few other things that are available which are not easily available in India. Is that there are sprays, inhalers, microtabs, and the mouth strips. So the common ones that are used and are actually quite easy to prescribe and get the patient to use is the gums and the patch. Yes, and e-cigarettes were something which were earlier thought could actually be a easy form of NRT. But as you all probably are already aware, is that e-cigarettes are actually banned in India now. So what is the dosing regimen for NRT? First coming to the gums, is that the gums actually comes in a strength of 2 to 4 milligrams per gum nicotine strength would be there. And about 6 to 8 gums per day are the ones which are recommended to be used. So it's usually that, gradually taper off, just like any other substance that we say, gradually you stop, then it will help you deal with the craving and withdrawal. Similarly, the gums also, the dose keeps coming down over a period of time and then stops. Usually it takes us about 3 months to actually get it down and stop completely. And the maximum dosage that is advised is that about 16 milligrams per day. That is, if the person is taking about 4 milligrams of gum, then he should not be using more than 4 to 5 gums in a day. So the technique what is advised for NRT gums is that chew and park technique. So basically this is that whenever the person has craving, he has to chew on the gum, which he starts chewing the gum. And once the person chews the gum, he has a very tingling numbness kind of sensation in the mouth with some peppery feeling is what is described. So this is basically the nicotine that has been released from the gum. So then the patient has to keep the juice in the mouth, and then he has to do it until the craving comes down, until that he feels that he should go back and take a smoke or pop in a bit of his gutka that he routinely takes. Until that feeling comes down, he has to keep it in his mouth and then immediately spit it out, but not swallow it. Because if the patient swallows it, it is actually, it causes gastritis, significant nausea, and sometimes can cause significant throat irritation, which can be quite distressing. So the patient has to be advised to spit out whatever juice that is after he feels that its purpose has been served. But the gum should be kept in the mouth itself. So the patient need not spit it out, each time he or she uses it, I'm having, so I use it, I spit out the gum. It's not like that. They can continue to use the gum for at least 2 to 3 times of the craving episodes that they have. And usually it takes about 30 minutes to an hour. Beyond that, usually this won't last. So he has to keep the gum between the teeth and the buccal in the buccal, and then take it and repeat the whole process of chewing and then putting it back between the buccal cavity as and when he requires. Yes. So this is actually, it appears quite easy, but actually discussing the technique itself sometimes becomes a challenge. Really motivating the patient that, you please keep trying and eventually you'll learn the technique. So next, the patch. So nicotine patch basically comes in doses of 7 milligrams, 14 milligrams, and 21 milligrams. It depends on the severity of the tobacco use. Somebody who's using heavily, they might require somewhere between 14 to 21 milligrams. And you can actually use a trial and error method. If somebody is not using many cigarettes or uses maybe 1 packet of gutka, you can start with a 7 milligram patch. But if he or she experiences still the craving continues, then you can increase the doses as and when required. And usually it is applied in a non-hairy part which is recommended. The person can apply it himself and also look for any reactions that he might develop. Regimen usually in somebody who uses heavy tobacco quantity is that 21 milligrams for 2 weeks, 14 milligrams for 2 weeks, and 7 milligrams for 2 weeks and stop. So it takes about 6 weeks period to completely get him off and also, and obviously the tobacco products. So you have to keep this advice to keep giving this advice to the patient is that, you don't use your nicotine patch or gum and also continue a tobacco product. So it is basically a replacement of that, and that it is necessary that he continues only the gum or patch but does not use the tobacco products. Yes, so the comparison between gums and patch. So usually nicotine patches are easy to use, like you've seen, every 24 hours he just has to change a patch. And so the, he doesn't experience the troughs and peaks of craving that, can do happen with nicotine gums. So it is a more predictable response. But the thing is, it's a little expensive. It costs about 100 rupees per day, depending on the doses and the patch quantity. Overall, the prices are coming down, but definitely it can work out expensive for somebody who doesn't have much income to give out. So gums is basically, the disadvantage is that the technique is actually difficult. So sometimes people don't feel comfortable with it. So when they end up stopping, they would rather go back and use the tobacco product rather than continuing the gums. And like I said, response is not very predictable. So every time he develops craving, he has to keep using it. So he doesn't experience the continuity of relaxation or absence of withdrawal symptoms like they see with patch. And other thing is, it's quite affordable and easily available. So they don't really have to spend much for procuring and using these gums. So any doubts or clarifications that any of you would like to know more about nicotine replacement therapy? Any queries in that regard?
Maybe we'll finish up discussion with the tobacco here only. Then we'll go for alcohol.
Yes.
Yeah, any questions, clarification or anything? Sir, any questions? If no question, we will go ahead for alcohol now. Yeah.
Yes, sir.
Nirisha,
so I'll skip the pharmacological medications. Yeah.
So just tell the names and duration kind of things. Yeah.
Yes, sir. Yes, sir. So there are actually a couple of drugs that are also available, psychiatric medications, and few drugs that have been specifically patented for tobacco. One is bupropion, which is actually an antidepressant drug, but has been shown to be beneficial for tobacco dependence. So it is 150 to 300 milligrams of XL preparation for at least 3 to 6 months in a patient with tobacco addiction. So the next one is varenicline, which is specific and only for tobacco addiction. It is actually quite expensive, comes up to about whole regimen, which actually comes as starter pack and a maintenance pack, like you can see here. So the total pack will actually cost them about 7,000 to 8,000 rupees. So it's quite expensive, and sometimes it does take time for the person to quit tobacco. So it has to, the person has to wait for some time. But it has been shown if somebody has been steadily using it, it's definitely quite beneficial to quit the tobacco. Yes. So I'll move on to alcohol then, if there are no queries. Okay. So, sir, shall I move on to alcohol use disorders?
Yeah.
Yeah. So next is alcohol use disorders. Like I mentioned, yes, sir.
Yeah. What about these nicotine patch themselves become addictive? Is there any chance?
So that is a possibility. We've been discussing it more predictable. So we have a control over it, especially the dosage of it. So there are instances where patients can actually become addictive to it. But it's again, we have more predictable response. We know what we can do about the dosing and everything. So it is in a way comparatively more safer option of nicotine addiction if the person actually becomes. But again, said nicotine in itself can cause certain problems, especially it can cause some adverse effects are there. It can cause difficulties with autonomic nervous system. So it has to be kept in mind that patient comes up and we know what rationale we are using and the regimen that we are using. So that is definitely a possibility actually.
Yeah.
But
What
it's
next,
very
madam?
commonly seen. Sir?
So, what next if they don't respond to
Yes,
these
sir.
things?
Like I said, it is actually, you have to keep trying and trying and trying. So ultimately for any substance for that matter, and especially with tobacco, it is quite challenging. So if person say quit for about 2 months also, we have to appreciate him that, look, it's good that you have, quit for these many months. It's good that you come back.
Karinur sir, I think it is a very wonderful question for the today's topic. Maybe we will handle it at the last because both are same for alcohol and tobacco.
Yeah. Okay.
Very excellent question. Actually, I didn't expect that people will ask, but it is a very good question. Coming to nicotine gum, sir, actually nicotine, tobacco has more than 200 chemicals, among which nicotine is the only addictive chemicals in the tobacco. So other things other chemicals are harmful to the body, but nicotine is not really harmful, except it become addictive. But in reality, the chances of getting addicted to nicotine gum or nicotine patches is very, very less. Even if it is getting addicted, slow tapering is one of the things which we follow it. Okay. And if this nicotine gum, and one of the problem in gum is that its palatability with the patient acceptability is very, very poor. And next comes nicotine patch. I am sure all doctors should understand about the nicotine patch, especially who are working in ICU setups. The people who have a tobacco addiction get admitted to ICU for various other causes, and nicotine withdrawal they will have. And in order to treat many of the people, if you just closely ask them why are they asking for discharge from the ICU, one of the reasons they say it is that tobacco is difficult to manage for them. If you just put them nicotine patch with them on their hand, and the desire for having tobacco will come down drastically, and you can manage the other medical condition for which you have admitted. That is the one thing. And for routine management, and you can use other bupropion medications and varenicline. Varenicline is little bit expensive medication, but it is really worth trying it. And varenicline, if you go with that, there are the starter pack and maintenance pack, easy to understand it. But it is little expensive, around 7,000 or 8,000 per 3 months. Okay. Yeah, go ahead for alcohol now.
Yes, sir. Thank you, sir.
Maybe you can finish in 20-25 minutes. So because some of the questions are good.
Yes, sir. Yes, sir. So next is alcohol use disorders. So quickly looking at the different forms of alcohol preparations that are available, I'm sure all of us know about these. Is that asking the patient what kind of alcohol they use, especially if somebody is using alcohol, kind of helps us calculate the amount of alcohol they clinicians of other specialties, if you're at least aware that a person who's taking beer also can become addicted to alcohol, even wine can be addictive. I think that should be good. And definitely some patients might say, I just take a little wine, or I just take one beer or so. So checking with these people also how frequently they use it is actually important. So next, different patterns of alcohol consumption. So all of us know about social drinking. So social drinking is something quite common. Most of the individuals have one or at some point in their life, at least most of them use at least one drink. So in males, usually it is quantified that social drinking is defined as where they don't drink more than 2 drinks per day, and for women it is 1 drink per day. Again, to remember is that this has been quantified for other Western population. So for Indian population, actually this might not apply, exactly, because the metabolism and our body, body mass index and the body fat and everything is different. So the metabolism of alcohol also is slightly different in Indian body kind. So it is important to remember that this might not actually apply to us. Next is binge drinking, where a person drinks heavily, maybe once in few months or so, and wherein he drinks basically more than 5 or more alcoholic drinks. And next, what is clinically important for us when we say alcohol use disorders is that harmful use and addiction. So these are the two things that we will be focusing and highlighting in today's this thing, is that because these are the ones which will commonly present to a clinical setting, either psychiatric setup or a non-psychiatric clinical setting. So these are the things that we'll be discussing in today's subsequent slides. Yeah. So the burden of alcohol use disorders, as per National Mental Health Survey in 2015-16, 9% of adult men had some form of alcohol use disorders, and more than 5.4% of total deaths were attributable to alcohol use, either directly or indirectly. And 62.9%, so more than 60% of deaths due to liver were directly attributed to alcohol use. So, and so again in 2009, people in India use alcohol, of which 2.9% had severe alcohol use disorders. So like I said, the clinically important forms that we need to know is alcohol addiction and alcohol harmful use. So next, how to screen for alcohol use disorders and how to diagnose them. So first screening questions, as given in our CSP manual, is that 3 simple questions that you can quickly ask in your clinic is that, in the past year, are you drinking heavily and regularly? In the past year, are you getting sleep without alcohol? This is indicative of withdrawal symptoms where the person has to take alcohol to sleep. And in the past year, are you getting a shaking of hands or body whenever you reduce or stop alcohol? This is again nothing but tremors which can appear when a person is having withdrawal due to alcohol use. So these 3 questions will quickly indicative that the person has alcohol use problem and most likely has alcohol addiction. So next, first coming to the alcohol harmful use. So basically alcohol harmful use term itself is that there is definite harm due to the alcohol use. There is dysfunction in the person's functioning and the person is experiencing health problems. But again, they are not taking it as regularly or as frequently to amount to dependence or addiction. So heavy alcohol use causing dysfunction, even if there is no regular use. This is important to remember because sometimes patient might actually downplay their use, telling, I don't drink daily, I just drink once or twice a week. So it's important to know that alcohol harmful use can be an entity in that patient or individual who comes to you. So what are the 2 types is that frequent use or infrequent use. Frequent use is when the person is using more than 4 times a month. That is at least once a week. And infrequent use is when they are using less than 4 times a month. Maybe twice a month or once a month, the person is using alcohol, but enough to cause problems whenever he uses alcohol. So next is alcohol addiction. Like I mentioned, through the screening questions itself, you can alcohol addiction. So again, regular use has to be there. Patient experiences withdrawal. And the other subsequent add-on symptoms that you can assess is that increasing quantity over time, experiencing again withdrawal symptoms similar to what happens with tobacco, neglecting their responsibilities and using despite knowing the harm. Like I'm sure all of you have experienced where you already come to the patient, you have hepatitis, you have fatty liver, or you have cirrhosis of liver that has already set in, so you have to stop drinking alcohol, but patient continues to use alcohol, and this is because the person is addicted to alcohol. So next is alcohol withdrawal. So what are its clinical features? Uncomplicated withdrawal or simple withdrawal symptoms that can occur in alcohol withdrawal is that tremors, wherein there can be tremors of hands or the whole body. Sleep disturbances are very common. Restlessness and craving to take alcohol, and sweating and palpitations. So others not so very common is hallucination. So patients can actually experience auditory hallucinations. They can experience visual hallucinations, which can occur in some individuals in withdrawal period. So next is the complicated withdrawal symptoms. So these are the ones which usually present to emergency with complications associated with seizures. So usually seizures are generalized tonic-clonic type. Anything other than GTCS, you should think of other causes, possible head injury or any space-occupying lesion or a stroke in that individual. And it occurs about 24 hours to 48 hours after last drink. Next complicated withdrawal feature is delirium tremens, which is characterized by generalized tremors. There is disorientation and the person is usually agitated. And this usually sets in about 48 to 72 hours after the last drink. So other complications that occur most commonly, which we need to be clinically aware that this is a possibility, is Wernicke's encephalopathy. So Wernicke's encephalopathy is characterized by ophthalmoplegia, ataxia, and confusion, that is disorientation. The cause is due to thiamine deficiency, which is a secondary to chronic alcohol use and malnutrition. So it is important to remember, if a patient with alcohol withdrawal, say, comes without hypoglycemia or anything, avoid using DNS. So dextrose or any form of glucose IV preparation should be avoided until thiamine supplementation has been given, because this can actually precipitate Wernicke's in such patients. So a quick summary of the timeline of alcohol withdrawal is that 6 to 12 hours, patient can have minor withdrawal symptoms such as tremors, craving, sleep disturbance, and sweat. 12 to 20 is a little bit more severe, where they experience tremors of the whole body. They become more restless, and some may experience hallucinations. 24 to 48 hours, some people may experience convulsions of GTCS type, and 40 to 72 hours, delirium tremens can actually occur. So this timeline is important because sometimes the patient is all right at the time of admission, and suddenly on day 3 or day 4, you notice that patient is extremely restless, or patient has thrown a seizure, but we don't know the cause. Especially this can happen, when somebody is come with trauma. So you sometimes miss out substance use, or they do not offer this information due to various reasons, and suddenly patient has had a seizure, and as a clinician, you can be clueless. So this, as my experience in General Hospital Psychiatry in St. John's, we would often encounter these issues, and only eventually after a lot of discussion and probing is that patient would actually offer the information to the surgeon. So this has to be noted, that sometimes patient can prevent, or they can refrain from telling the information for alcohol. So next is management. So the general guidelines that you need to follow for all substance use disorders, for alcohol and tobacco or any other substance that you might encounter, is that relapse is a rule rather than an exception. So Dr. Madhusudan was asking us some time back, is that what if the patient comes back? What if this patch does not work? What if the drug does not work? So this is actually a rule. So and persistence in treatment is what is necessary. So even if a patient comes back, we'll probably have to restart the whole process again. But that is the whole cycle of substance use disorders and addiction. So we need to be persistent whenever we are handling substance use disorders, and always evaluate for medical complications. So this can again be a motivating factor for the person to quit, and also to ensure that a patient has been treated adequately with respect to all the medical issues that may arise due to the substance. If a person is unwilling for treatment, especially somebody is using a little bit of alcohol or tobacco, he might say that I don't feel there's a need to stop the substance, or I don't want treatment. So this can be a common scenario that we all encounter. So is that it is important to lay emphasis on the therapeutic relationship. So basically, no need to get upset, no need to get angry with the patient that I'm trying to counsel you, why are you not stopping? You have to stop. So this actually does not really work. So usually establish that, okay, you don't want to stop now, please come back to, when you feel like quitting or develop diseases, problems, come back and tell me, then we'll see how we can help you. So establishing a good therapeutic relationship is quite essential. Post-treatment, sometimes patients' families might actually tell you, doctor ಕೊಟ್ಬಿಡಿ ಅದೇನೋ ಮಾತ್ರೆ ಇದೆಲ್ಲ ಅದನ್ನ ಕೊಟ್ಬಿಡಿ ಇಲ್ಲ ನೀವು ಅದನ್ನ ಮಾಡ್ಬಿಡಿ ಇದನ್ನ ಮಾಡ್ಬಿಡಿ ನಾವು ಹೆಂಗೋ ಮಾಡ್ತೀವಿ ನಾವು ಊಟದಲ್ಲಿ ಹಾಕೊಡ್ತೀವಿ. So actually you should not force treatment, because if the person thinks that forcing or coercing him to take treatment, the therapeutic alliance may be lost. Counseling about ill effects of substance is very important, and benefits of substance, stopping the substance, that there may be alcohol or tobacco, and inform and discuss the treatment options available. Counseling and engaging family is very important in any form of substance use, because often their criticality, their negative reactions to the patient might actually lead to relapse, or the person might refuse to come to treatment because anyways, my family is going to behave badly with me. So what's the point of taking treatment? So engaging the family in treatment is very important. So next, to coming to the actual addiction management for alcohol, is first step one is detoxification, basically to help treat the withdrawal symptoms. And benzodiazepines are the ones which are used for withdrawal symptoms. Diazepam is the one which is a long-acting benzodiazepine, so it actually has more benefit in terms of handling the withdrawal symptoms. So maximum dosage in a clinical setting without an ICU, without any additional help available, recommended is about 40 milligrams. If withdrawal symptoms persist or the person is requiring higher doses of diazepam, it's better to refer to a psychiatrist and preferably keep the patient in a higher center, because at higher dose of diazepam, there can be cumulative effect and the person can have respiratory depression. So the regimen here is that every 2 days, you keep decreasing 10 milligrams, and ultimately by the end of 1 week to 10 days, you stop the benzodiazepines completely. So this regimen is very similar to using lorazepam, but wherein more frequent dosing might be needed. But you'll have to calculate the dose equivalents, which I think is not relevant at this point. But if you know that, yes, benzodiazepines can be used, diazepam is a good drug, I think that is good. So next important step in detox is the thiamine supplementation. It is again to replenish thiamine stores and to treat the deficiency, preventing wernicke's encephalopathy. So if to prevent wernicke's encephalopathy, it's immediate whenever patient comes either for any other medical problem or anything, remember to give a dose of multivitamin. So 1 ampule IM, if platelet counts are normal, can be given for at least 5 to 7 days. If platelets are low, you can give it IV. And oral thiamine supplementation, at least 300 milligrams equivalent, in capsule form or tablet form, should be administered for at least 3 months. So next step in alcohol use disorders management is the use of anti-craving agents. So these are basically drugs which help to handle craving and decrease the chance of relapse, and safe and do not cause any adverse reaction if the patient consumes alcohol by chance anytime during the period after he has stopped alcohol. So this is one lot of myth that patients have, is that, if ನಾನು treatment ತಗೊಂಡ್ರೆ ನಾನು by chance ಏನಾದ್ರು ಕುಡಿದ್ಬಿಟ್ರೆ ಇಲ್ಲ friends ಹೇಳಿದ್ರೆ ನಂಗೆ ಮತ್ತೆ ಏನಾದ್ರು reaction ಆಗ್ಬಿಡುತ್ತೆ, ನಾನು ತಗೊಳಲ್ಲ. So anti-craving agents have this benefit that if at all patient consumes alcohol also, there won't be any problem. And it can be started from the day 1 of treatment. That is, as and when you're starting alcohol detoxification, you can initiate anti-craving agents. And the drugs that are available are acamprosate, baclofen, naltrexone, and topiramate. So what are the dose regimen that you can use? Baclofen, up to 40 milligrams can be started with detox, as in the day 1 you can start. It is known to be helping with withdrawal symptoms as well. Advantage is that baclofen can be safely used with persons with liver dysfunction also. So you need not worry if a person has deranged LFTs or already cirrhosis has set in. Even in such patients, it can be safely used. So the regimen goes like you keep increasing 10 milligrams every 3rd to 4th day until you reach about 40 milligrams. Some patients can tolerate higher doses. So some individuals actually tolerate up to 100, 120, but it depends again on tolerance level. So 40 milligrams to 60 milligrams is what is recommended. And it should be continued for at least for a period of 9 months. So patient has to continue using baclofen for at least minimum period of 9 months, or any anti-craving agent for that matter, to ensure that he develops adequate benefit of these anti-craving agents. So next drug is topiramate, 25 milligrams every 2 days, increase up to 100 milligrams. Advantage is that of this drug is that it can be given to a person even who's unwilling to stop alcohol. Somebody who's drinking excessively but doesn't want to stop, you can use topiramate, because it has been shown that it actually decreases the alcohol quantity that the person uses. So the concept here is harm reduction. So somebody who's taking, say, 3 quarters and, after using topiramate, he comes down to 1 quarter. So there is some amount of harm that was occurring due to that excess alcohol use definitely comes down. So harm reduction is something that you can ensure. But adverse effects are, it can cause loss of appetite and fatigue, which is quite common. And sometimes if the person does suddenly stops, topiramate, he can develop a seizure. As you all know, it is an anti-epileptic drug. So next drug is naltrexone, which is basically an opioid antagonist. Usually it is recommended to start it only if LFTs are normal. And dosage is about 25 milligrams OD, can increase up to 50 milligrams if the person has no adverse effects. Advantage is that similar to topiramate, where I talked about harm reduction, it has also been known that if somebody continues to use alcohol, despite prescribing and detox, it actually reduces their need to consume more alcohol. Basically, they don't experience the same kick or pleasure with alcohol. Adverse effects with this drug are loss of appetite, nausea, and some individuals actually experience significant restlessness in the initial few days of treatment. If person is not tolerating, then probably you will have to change the anti-craving agent, but otherwise you can continue it at least, again, like I said, for a period of 8 to 9 months. So harmful use management, now we have spoken about addiction management. So now what to do if a person has just harmful use? So like I mentioned, non-pharmacological strategies, counseling is very important. And somebody with frequent use, somebody who's using more than 4 times a month, naltrexone has been shown to be beneficial. So the day he starts drinking, or the time he starts drinking, half a tablet of 25 milligrams of naltrexone can be used. This actually helps to cut down the alcohol quantity they use, and eventually helps to decrease the frequency because he doesn't enjoy every time he drinks alcohol. The person tends to stop alcohol. Thiamine supplementation, even in these individuals, is a must. So what are the other strategies that you can discuss with the patient along with anti-craving agents and counseling? Is it 5 Ds. So these 5 Ds are a very easy way of teaching your patient in your clinic. It doesn't hardly takes time as to how they can deal with the craving for substance. Is that delaying the use? They don't take the substance whenever they feel like they have to take it. Distract from the thoughts of substance use, try to engage in other activities, try to think about something else or become busy in some other productive habit or hobby. Discussing with family and friends, again with non-substance using friends and family, because somebody uses substance would actually say, okay, go back and drink or go back and let's have a puff so you'll feel better. Drinking juice or other food. Basically, the rationale here is somebody who has a full tummy, somebody whose hunger is taken care of, they don't develop craving because already endorphins, everything have been released. And deep breathing exercises. Relaxation exercises help them deal with the autonomic arousal that occurs with craving and the withdrawal phase. Yes. So lastly, coming to lapse and relapse. So basically, this is the cycle that we all will go through while managing patients with substance use disorders. Lapse is basically patient comes back, after 2 weeks saying that I just had a drink yesterday, or, I just had 1 packet of gutka, or my friend just forced me. Relapse is basically when he restarts the substance, to previous dependence pattern. So addiction has set in again, and relapses and lapses are quite common when you're handling patients with alcohol dependence. And what is the management of it? Again, like I said before, no point in getting upset with them because, if you get upset with them or if you get angry with them, they're unlikely to come back to you. So encouraging regular follow-up, not criticizing the patient, and that as a patient may not come back to take help from you again. If there is only a lapse, then encourage the patient to continue the drugs that you have prescribed, whether it's anti-craving agent or any other medications. Call for quick follow-ups and check for any ongoing stressors. It could be job stress, it could be a financial stress. Check with them if they're undergoing stressors, because often these are the reasons for lapses and relapse. If there's a relapse, again, start the whole cycle of detoxification and continuing the anti-craving agents. Yes, so I'm done with my alcohol use disorders. So basically, the concept and the strategies that we've discussed actually apply for any form of addictive substances. But since we are more commonly encounter tobacco and alcohol in the general medical setup, it is important that we know at least these two definitely. Yes. So over to all of you. If you have any queries or doubts, we can now discuss.
Thank you, Nilisha. Before the question asked by people, I would just tell how we conceptualize the alcohol and tobacco addiction, how we do management in day-to-day our practice. I'm talking about a psychiatrist perspective. I'm sure if you know this thing, you will also understand it better and you can implement it in a couple of minutes consultation of yours. For example, I always try to give 2 examples to make doctors understand about the alcohol and tobacco addiction. One is the personal example. Second is a medical, other medical condition examples. One is personal example is, for example, how many times in our life we had a target of achieving, going for a early morning jogging. At least once in a year, we will plan for 2-3 days, 4 days, then again we'll stop it. So, but we that stop it only for that moment. Again, after some time, 6 months, 1 year or 2 years, again we'll plan it. So this cycle will keep on going even for regular our lifestyle illness like obesity. Coming to diabetes. are we achieving, are we telling that the success rate of diabetes by giving one anti-diabetic medication in one first prescription? We don't assess the effectiveness of anti-diabetic medication by giving one prescription. So same principle applies in our addictions also. Next, coming to alcohol, and for example, if patients, even if you give better anti-diabetic medication, there is a euglycemia is controlled for many 1 or 2 months. Then suddenly, maybe for various reasons, including he might have had a sweets or some feed food sometime, and he has taken and sugar level gone up. And that point of time, he has stopped anti-diabetic medication also. Think that way. What do? Again, you will begin your recycle of the starting the medication anti-diabetic and try to control. So similar principle we use in alcohol and tobacco to make it very simplified. And very good breakthrough in alcohol addiction is that I think she has not spoke about disulfiram or anti-abuse medication, which earlier was the only cornerstone medication, and these days we use very rarely for very, very highly motivated patient, because there are medical legal complication may arise with prescription antibiotic, anti-abuse or a disulfiram, especially if there is no consent from patient. So breakthrough medication is anti-craving medication. For example, I will tell you how anti-craving medication. Even if person is drinking alcohol, he will ensure that anti-diabetic medication is taken, anti-hypertensive medication is taken. Even he is taking alcohol, in half of the in session of the alcohol will come out in another matra idre tagondella bandbiಡ್ತೀನಿಲ್ಲ ಆಮೇಲೆ ತಗೊಳ್ಳೋಣ, some kind of that thing, and people continue to drink even after taking antihypertensive and diabetic. So anti-craving medication also having same advantage. But how does it helps in alcohol is that it reduces their desire of amount of alcohol they drink, and they reduces the desire, and next day the withdrawal symptom severity will be very, very, very less. So this is the way it will help it. So now it is open for questions and clarification or anything, feedback there.
Sir, Dr. Anusya has actually asked a question in chat.
Yeah.
Madam, would you like to ask your question?
No, you can read it.
Yes, sir. So madam has asked, actually in pregnancy and alcohol and smoke addiction, can we treat it, and what is the line of management in such patients? So as we discussed, I think women substance use is actually quite common, and definitely it does affect if a person is in the reproductive age group. Planning pregnancy is already pregnant, so definitely alcohol and tobacco use has to be refrained. So the drugs that we can use are quite minimal. Definitely we'll have to exercise caution in prescribing drugs, because most of these drugs are actually teratogenic, so they cannot be used routinely. So most likely a lot of non-pharmacological intervention, having a multidisciplinary team, having the obstetrician, the psychiatrist, everybody on board will have to work with the women, with the mother, whoever is pregnant, and definitely encouraging the person to stop substance as early as possible is what we have to do. But the drugs that we'll have to use, definitely we'll have to exercise some caution, because like I said, benzodiazepines are contraindicated in early pregnancy. A lot of our anti-craving agents cannot be used.
My suggestion is that to madam is that, for example, what we have spoken is we try to simplify for all MBBS doctor understanding. But when pregnant lady comes with alcohol or smoke addiction, if you are sure that way, probably it is good idea to involve psychiatrist rather than treating you.
Yes.
It is not easy
exactly,
to treat in this condition, because you are handling multiple things.
Yes.
So probably nicotine addiction, what we do is that nicotine replacement therapy only we will go, rather than we go for bupropion or varenicline. I am talking about general things. Alcohol, if there is no seizure or DT, then it is, we try to just, giving benzodiazepine is also a problem in pregnancy. We have to go, maybe we should use the short acting benzodiazepine for detoxifications. Definitely topiramate we don't advise. And if there is anti-craving is there, then maybe baclofen is a better choice compared to other things. This kind of things are there. It is probably involve a psychiatrist rather than treating yourself. If these conditions are not there, it looks very plain. Definitely all MBBS doctors are encouraged to treat at your level. Yeah. Next, any questions?
Yeah, thank you, Dr. Lakshmi Nirisha. I am Dr. Prasad.
Yes, sir.
Yes, sir.
Yeah, sir. I would like to know, see, in Bangalore, in now cities, these all these wine stores and all, they have become like supermarkets now. So whether that is having influence for increase consumption of alcohol, and is it anything is there like that? Like the sight of that, it may make the person to go back.
Sir,
Or they will socially it becomes an acceptable thing when it becomes large number of market, just like a supermarket, wine stores, everything is coming up like that, especially in cities like Bangalore.
Sir, actually, it is what is the question you asked. You have an answer also. We tend to agree. Even research has says easy accessible to alcohol increases the usage of the alcohol in that area. So even WHO talks about it. Access, whenever it comes, you reduce the access, the quantity of alcohol will come down. It is a general public perspective. But that I don't know whether that really helps in clinician when we are sitting in front of patient in clinics. That may not be, we don't need to think in that way. So it is only public health perspective, public policy makers that will be helpful. For us, it doesn't make any of these, but we, for just common sense approach or layman, that is good questions. But for clinician, definitely you don't think on that part. When patient comes to you, you treat like that. Whether he has access, not having access, whether he has a local like alcohol, or it doesn't matter. Alcohol is alcohol at the end. Yeah. Yes, sir.
Thank you, sir. Thank you.
Thank you, sir. Sir, Harish, hello. Karinur, sir, I think you got your answer for your questions. Karinur, sir, I think he has left.
I think he's not. Is he left? I think I don't know.
Yeah. No problem.
Yeah, just one comment, sir. Sir, one comment.
Yeah, please go ahead.
Yeah, with respect to the COPTA Act, because Madam, and it was a very nice presentation by Dr. Lakshmi Nirishka. And as it was in the last week also, this week also, it was another good cake we had. So with respect to the role of doctors, not only psychiatrists, all other professionals, professional doctors, in implementing the COPTA Act. Nowadays, what is happening is, with respect to the COPTA Act, only government officials and police officials are trying with respect to a little bit. That also not with the full this thing. So now all the doctors should educate the public, whoever comes to their clinic, with respect to COPTA Act, as well as display the board. That's what I feel on myself, so that we can better propagate this thing. IC activities can be done on this.
No,
so what is your take,
I agree with you as a public health perspective. See, it is very good concept till patient enters your consultation room. When he enter the consultation room, your primary focus is for other reason for which he came. So probably waiting hall or something, you can display the public education material about tobacco. You should not use alcohol in public space. All these kind of things you can put it. But when patient comes inside the clinic, your business is to handle what for which he has come. Yeah, right. So that is a public health perspective. I'm sure you are a public health person. I am also a public health person. But when it comes to inside the clinic, I don't think it matters much. Yeah.
Sure, sir. Thank you.
Yeah. Anybody else has any question?
Sir, I'm Dr. Uma Sheshgiri. So the presentation, I want to congratulate Dr. Lakshmi, who has wonderfully explained everything. I really understood everything. But only thing is, I think it is too elaborate. And I feel if there is any, as you said, pregnancy and all with alcohol addiction, it is better to refer to you people. That's what I feel. But otherwise, I think basic we all can manage after listening to you. We have to actually put our efforts over there. That's what I feel. Thank you so much for the presentation.
Thank you.
Dr. Lakshmi, there is in the chat box, there is some question about pregnancy and alcohol and tobacco addiction.
That we have discussed.
Sure.
That we have discussed.
Thank you, madam.
So I think one point that I have to raise is like tobacco. I think government has tried a lot. Like, they've had these bizarre cancerous lesions. They've had lungs with COPD lungs and everything, but somehow it doesn't seem to have affected. I think when patients come to the clinic, come to us, that one-on-one discussion with them, telling what are the benefits, what are the pros and cons, I think probably that's what motivates them to stop. So I think a lot of these things have actually largely not been very successful. So definitely when they come to a clinic, that one-on-one individual interaction, that therapeutic relationship is what actually makes a lot of difference.
There are two things here. One thing is a public health activities, where a lot of videos is shown, and before the picture there are a lot of cancerous patients, all these things shown. But how does it help? So you are scaring people not to use it. But that doesn't help, because that the addiction is biological in nature.
Yes.
So, and nowhere in this public health material, how to stop it, nobody tells.
Exactly.
People say that it is a problem, it causes cancer, you stop it. But how to stop it, nobody talks. That is one of the things. One of the problem with public health perspective of the alcohol. And coming to medical doctors, and I am sure majority of the MBBS doctor doesn't know there are medications available for tobacco addiction. Maximum the doctors knows about only gums, and these days some people are knowing patches. But how many doctors knows about bupropion usage in tobacco or varenicline usage in tobacco? It's very less. And even surprises, because that is why I shared my first experience of my DPM in 2002 and 2004. Within 2 years, initially I was not asked to take the tobacco history, but 2 years we have changed. In 15 years, I am sure doctors should start prescribing a medication, try it out with many patients and see which one is helping for your patients. So all MBBS doctors are equipped to do that kind of medication and try to experiment with your patients, because it is well versed. Many of the time we have used rampantly. Yeah. Thank you.
So there is one question, sir. Dr. Purnima has asked a question in chat. So madam wants to know what are the ways in which we can quench the curiosity of teenagers and college going students about exploring the use of tobacco and alcohol.
I think this is not the thing which we are focused today, but question has come, you have to answer it. And I would tell you, madam, there is a curiosity based of usage of alcohol. Less than only 10% of people who has curiosity used are become addicted in the long run. But 90% of the people, they just taste it once or twice and they leave it in long run. So I don't know how it's a long-term course and prognosis of this thing. It's very difficult to predict as a clinician what will happen. Only thing is public health perspective, you can say that if you continue to use alcohol, you will have a lot of problem. So maybe best not to use it. Curiosity is there. People use once or twice and they stop it after. Yeah.
Yes.
Okay, I think there are no questions right now. Madam, can you stop sharing your screen?
Yes, sir. I'm doing that right now.
Yeah. So Manjunath sir, with your permission.
Please.
Okay. With the permission of all the seniors of IMAKSB as well as IPSKC, I thank Dr. Lakshmi Nirisha for giving us a lecture on tobacco and alcohol addiction in this paid series of IMAKSB, NIMHANS and IPSKC. I thank the coordinator, the moderator of the today's session, as well as the mentor for all of us, most of us, Dr. Manjunatha, Associate Professor of NIMHANS in the Department of Psychiatry in NIMHANS, Bangalore, for his valuable guidance. And I thank the IMAKSB President in his absentia, Dr. Venkatachalapati sir, and Vice President Dr. Shiri Madam, and Secretary Dr. Vice President Secretary sir, as well as our IMAKSB President, IPSKC President Dr. Karanth and Dr. But respectively, and all the participants on behalf of IMAKSB and IPSKC. And my special thanks to Dr. Madhu, who is my classmate, who is my friend, and immediate past president of the IMAKSB for this wonderful series which has initiated by him. With the permission of seniors, I would like to end the show. Thank you, one and all. Thank you very much. We'll meet again in the next series. Thank you, one and all. Good night.
Good night.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Thank you.
Good night, sir.